Okay everyone, well welcome to this video on shoulder sonography. We're just going to run through a typical shoulder ultrasound that most departments, radiology departments in Australia, this is how they would perform a scan and the structures they would be looking at. So if we just have a bit of an anatomy refresher to start with, we all love our anatomy.
Yes.
So we've got Michael here as our model. Thanks very much, Michael. So I break the shoulder up into sections, just like in the elbow and the foot and the wrist. You break it up into compartments and you compartmentalize the anatomy and it helps you to remember it. So if we're going to look at the anterior shoulder, we're going to look at the long head of biceps. We're going to look at the subscapularis tendon, which sits through here. We're going to look at the coracoacromial ligament. Now, the orientation of the coracoacromial ligament varies quite a lot depending upon the patient. Some people it's quite vertical, other people it's quite horizontal. Then if we move to the lateral aspect of the shoulder, we'll look at the supraspinatus tendon. Posteriorly, we're going to look at the infraspinatus teres minor, posterior glenohumeral joint, the infrascapular notch or the spinoglenoid notch. And then if we move up here, there should be a hole. This is the spinous scapula here. There should be a hole through there. We would be looking at the suprascapular notch sitting up here. That's where the subscapularis nerve passes, and that can get impinged upon from fluid from the glenohumeral joint in the shoulder. Then if we move to the anterior aspect of the shoulder, we'll be looking at the acromioclavicular ligament, and we'll be looking at the supraspinatus tendon and the associated subacromial subdeltoid bursa as the patient abducts their arm, looking for impingement. So let's get started. So patient position is important with any ultrasound. You need the patient to be as comfortable as possible and you need to be comfortable. If you're scanning and it's uncomfortable, A, it causes musculoskeletal problems, and B, you start shaking. Remember, we're looking at structures that are in the order of 1 millimetre to 0.5 millimetre in size sometimes. So you really don't want your hand shaking as you're doing that. So we'll start with a little bit of gel on the shoulder here. Now you don't need to drown the shoulder in gel, right? But you do need to have enough gel that the ultrasound probe can slide freely around the shoulder. So we're going to start with a long head of biceps. So palm up, elbow flexed, just resting on the patient's lap comfortably. Probes in the transverse or axial plane. And I scan down the anterior aspect of the humerus, looking at for the cortical margin of the humerus, which we have sitting through here. And over the top, where this little dip is the bicipital groove. Now the bicipital groove varies in size. Some people have quite a narrow, deep bicipital groove. Other people have a very shallow groove. Other people, like in Michael's case here, have quite a wide bicipital groove. This is medial over here, lateral over here, and here's our long head of biceps tendon sitting on that medial edge of the bicipital groove. We would externally and internally rotate the arm, looking to see if that long head of biceps pops out of the groove. Does it sublux or does it dislocate? If it dislocates, it goes completely out of the groove. Everything's happy there, so freeze, first image there. Next, turn through 90 degrees, looking at the long axis of the long head of biceps. So let's check our imaging parameters. We're probably in a bit more depth because the tendon's disappearing off the screen here, so we'll increase our depth slightly. Our focus, we can narrow that down and drop it down. There we go, that's looking better now. So heel toe the probe, so pushing your probe in, so you stay at right angles to those fibres of the long head of biceps, going down the arm till we get to that musculotendinous junction, making sure there's no fluid, making sure you've got a nice fimbrial pattern. And that would be our next image. Then we go back up the arm proximally again. We've got the bicipital groove. Let's shift our focus up. Keeping your imaging parameters optimized is very important in sonography, but it's especially important in musculoskeletal where the structures are so small. So transverse over that bicipital groove, there's our long head of biceps again, keeping the arm sort of flexed and palm up. This time though, we externally rotate, and now we've brought the fibres of the subscapularis into view. So if you can just hold your arm there, Michael, lovely, thank you. So you can see this is our subscapularis tendon. Is the insertion onto the lesser tuberosity of the humerus. Over the top we have our deltoid, subcutaneous tissue and skin. Subscapularis is a big tendon like the supraspinatus, so make sure you survey all the way through, inferior to superior, looking at that cortical surface, looking to see if there's any erosive change, looking at the fimbrial pattern, making sure that's maintained, and you've got the nice white and black lines of the fascicles surrounded by that endotenon, and then looking at the surface of the tendon to make sure that's nice and smooth. Now, there's no such thing as a subscapularis bursa. So if you see fluid sitting up here, it's not a subscapularis bursitis because there's no bursa there, right? It's fluid coming from the shoulder joint. So one of the ways we test for that is by internally and externally rotating the arm, seeing if we can drag fluid out of the shoulder joint so it becomes apparent. Now you need to do that 3 or 4 times. Once isn't good enough. It can take a few times to get that fluid to come out. But in this case, that's lovely. And that would be our next picture. Now, like I said, subscapularis is a big tendon. So we're looking at it in the long axis. When I talk about orientation, it's orientation to the structure, not the patient, okay? So it's the long axis of the tendon there, turn through 90 degrees, now I'm in the short axis or transverse plane. So here's our subscapularis again, and you can see here we've got these alternating areas, so echogenic areas and more hypoechoic areas. Subscapularis has got 4 to 5 heads, so what that means is there's 4 to 5 tendinous slips. So you will see in the normal tendon, we'll zoom that up a bit, in the normal tendon, these hypoechoic areas adjacent to hyperechoic areas. Perfectly normal. Don't go calling that a tear or degenerative change. And then just survey through the subscapularis, and that would be our next picture. See how I'm heel toeing the probe a bit so that I get more at right angles to those tendon fibres so I can examine it all the way through. Next image. You can have the patient relax their arm now. Next thing I'm looking at is the coracoacromial ligament. So that's the ligament that stretches between the coracoid and the acromion. Difficult to see when you're first starting shoulder ultrasound. A lot of people struggle with that. The way I find it is I find the long-headed or the bicipital groove again, so we've got it there. Move the probe medially, still in the transverse plane, until I can see the echogenic surface of the coracoid, which we have here. Now, I keep one end of the probe over that coracoid and then rotate my probe clockwise until the echogenic surface of the acromion comes into view. Over here. Stretching between the coracoid and the acromion is the coracoacromial ligament. Let's get that focus up a little bit. It's a bit too low. We want it over the area we're interested in. And now we're going to externally and internally rotate the arm. What we're looking for is if deep to this coracoacromial ligament we can see a black area or a hypoechoic area. That can be a tear within the supraspinatus tendon. So it just gives you another window to see that tendon. So that would be our next image. Then we move to the lateral aspect of the shoulder. So what we want to do is flex the elbow like Michael has, and then we want to draw the arm back. What that does is it pulls more of this supraspinatus tendon here out from under the acromion. By drawing the arm back, you can pull the tendon out so you can see more of it, because we can't see through bone. Now, in practice, you will often scan with the arm behind the back like this when you first are examining the supraspinatus tendon. That will pull as much of the tendon out as possible. In this case, we're just going to draw the arm back like that. So this is how I would image the tendon. When I first start scanning the tendon, the arm would be all the way back. But for this case, this is how we're going to keep it, because we can still see quite a lot of the supraspinatus tendon. I'm just going to increase that gain a little bit. So the supraspinatus tendon, it should look like the beak of a bird or the nose of the Concorde, they used to say. So large tendon, about 2¼ centimetres in diameter. we need to go from the anterior aspect all the way to the posterior aspect. Then you ask, how do you know what's anterior and how do you know what's posterior? Well, the long head of biceps is what defines it for us. So we can see here, here's our long head of biceps, here's our subscapularis and supraspinatus. Everything posterior-lateral to the long head of biceps is the supraspinatus tendon. Anterior is the subscapularis. So if we identify that long head of biceps, we know that everything posterior and lateral to it is the supraspinatus. So let's find that long head of biceps tendon. So I've got the probe along the longitudinal plane of the supraspinatus tendon, sliding the probe anteriorly, and what we're looking for is a fimbrial structure, like a tendon, funnily enough. So we keep going, and there we go. That fimbrial structure, so we've got the supraspinatus here, keep moving anteriorly, sort of goes all fuzzy, and then that bright echogenic line, that's the long head of biceps. So move posteriorly, that would be the anterior supraspinatus image. So looking at the greater tuberosity of the humeral head, as that starts to get a dip, there's our mid-supraspinatus. As that dip flattens off, there's our posterior supraspinatus. So they're the three longitudinal images of the supraspinatus tendon that I take. Make sure as you're assessing the tendon that you have a nice smooth contour, that the cortical surface is smooth, there's no erosive change in there, that the echogenicity of the tendon is consistent throughout. There's no focal areas of increased echogenicity that you might get with calcific tendinosis. That the bursa, now the bursa is a really fine structure in normal people, so let's try and see that. So we're going to decrease our zoom, we're going to decrease our depth. Now I'm going to increase the zoom again, narrow my focal zone all the way down, reduce my 2D gain to get rid of the flare in the screen, and the subacromial subdeltoid bursa is this tiny little black line in here. So the bursa actually has two walls with a black line in the middle, right? That's why it's called a Vegemite sandwich. So you've got two pieces of white bread with the black Vegemite in the middle. So that's the bursa there. If I freeze the image and measure that, this is where we would measure the subacromial subdeltoid bursa. Right? Normal varies. I'm not a big fan of normal measurements because you can have normal for one person is different to another person. Typically it's not more than about 3 millimeters. Okay. Now over the top of our subacromial subdeltoid bursa, we have the deltoid muscle. That's why it's called the subdeltoid bursa. Then we have the subcutaneous tissue, and then we have skin. Next, I will look at the supraspinatus in the transverse plane. So turning the probe through 90 degrees, sliding anteriorly until we identify that nice echogenic long head of biceps. So everything anterior is the subscapularis, posterior is the supraspinatus. Then we want a nice smooth curve to the cortical surface of the humeral head, so you know your true transverse, and we look at the contour of the supraspinatus tendon to make sure that's nice and smooth, and the internal echo texture of the tendon. And then I'll go down to the insertion, and then back up towards the musculotendinous junction, correcting for anisotropy by angling the probe as I go. Then I would take an image in the anterior supraspinatus, mid-supraspinatus, and posterior supraspinatus. Now we'll move to the posterior aspect of the shoulder. So hand over the chest. You don't need to drag it up around their neck, right? Just sort of the middle of the chest is fine. That just stretches the tendons of the infraspinatus and the teres minor out so you can see it better. Just rotate the patient here a little bit, and then we'll look at this posterior shoulder. So we know from our anatomy that the infraspinatus tendon travels around and attaches to the posterior aspect of the greater tuberosity here. Our teres minor is a little bit lower and comes up in like so. So that's how we'll put our ultrasound probe. Let's just increase our depth a little, drop our focal zone down a bit, and here we go. There's our infraspinatus tendon inserting into the humeral head. Just have a look through that, look at the cortical surface, look at the tendon architecture. That would be my next image. Then for the teres minor, you need to move a little bit more posterior and inferiorly, and we're looking for that glenohumeral joint. So we're going to increase our depth, drop our focus down. Right. Now this is where you can struggle, especially in male patients with big shoulders, to get that depth of penetration. Occasionally you might even need to go to the 9 megahertz vascular probe to be able to see. So let's increase our zoom here, and where we're interested is this is the humeral head, here's teres minor sitting over it, and here's the posterior labrum, this echogenic inverted triangle. So we're going to externally and internally rotate the arm, looking for excessive fluid within that shoulder joint, looking to see if the shoulder just rolls freely, looking to see if fluid tracks out through here into the infrascapular notch. That would be the next image. Then we move a bit more medial, looking at the dip in the subscapularis. There's our infrascapular notch. And then to find our suprascapular notch, we've got our spine of scapula here. We just move superior to that, angle inferiorly, looking for the cortical surface, and there's our suprascapular notch. And that's the posterior cuff. That would be our next image. Then we'll drop our depth down. We'll just adjust our imaging parameters, focus up, because what we're going to be looking at now is our AC joint, or our acromioclavicular joint. So we don't need as much depth in our image. That allows us to see the nice, the acromioclavicular joint filling our field of view. The last thing you want is all this depth, so the thing you're interested in is right up here, and all this is wasted space. So let's optimize our imaging, bring our focus up so it's covering what we're interested in. And here's our acromioclavicular joint. Here's the joint capsule. Here's our clavicle coming into our acromion. What we're interested in is this joint capsule nice and smooth? Are the cortical margins of the bone nice and smooth, or is there osteophytic spurring? As we lift the arm up and down, the acromioclavicular joint's allowed to move a little bit, but it shouldn't wobble like this. That can indicate an unstable joint. That would be our next image. And then we're going to assess for subacromial subdeltoid impingement. So draw the arm back again, because we're going back over to the supraspinatus tendon. Now it's important that when you assess the patient for impingement, that they abduct properly. What I mean by that is, when I ask them to lift their arm, I don't want them hunching their shoulder, right? I don't want them bringing their arm forwards. I just want a nice straight lift out to the side. One of the reasons I rest my hand on the patient, A, is to maintain probe stability and to save my shoulder, but B, is when the patient abducts, I can feel what they're doing. Are they hunching the shoulder, or is it just a nice straight lift? And what we're interested in is whether or not the supraspinatus tendon and the associated subacromial subdeltoid bursa over here, they should just disappear underneath the acromion as the patient abducts their arm. If they bunch and jam up, that's sonographic evidence of impingement. So let's just lift the arm, and the tendon just disappears. So we'll come back to the acromion. So we've got the echogenic acromion here. Here's our supraspinatus tendon, and once again, just lift up and the tendon disappears. No evidence of bunching or contour deformity. So that's passive abduction. That's me lifting the patient's arm. And then I also, now that the patient knows how to lift the arm, I ask them to lift it up. So can you just lift your arm up now, Michael? And that disappears freely. And that's a shoulder ultrasound. Thank you.